Hey everyone. Pulmonary diseases are going to be pretty important on the USMLE. As you know, lung cancer is the #1 cancer of both men and women in the United States. Asthma is extremely common. COPD is a mainstay for any hospitalist. So having a good background on the physiology of basic breathing is going to be important. There's going to be a lot of physiology on the exam, so I thought we could spend some time talking about it. You don't need to know the intricacies of the physiology, but having a good concept on the physiology is going to be important for understanding the diseases in the appropriate spectrum that you're going to need to, both on the exam and on the rounds. Okay, so we're going to talk about lung volumes, then we're going to talk about spirometry, which is a test that involves lung volumes and helps us determine whether the patient has an obstructive or a restrictive disease. We'll talk about what obstructive and restrictive diseases are in very little detail. We'll talk about flow volume loops, and then we'll talk about two different things that can tell us what kind of disease we have other than obstructive and restrictive diseases, which are the AA gradient and the CO diffusion capacity. Okay, so this is kind of just a crude image of lung volumes. So basically, as we're breathing, as you breathe at rest, that's considered your tidal volume. The amount of volume that you have in your, the amount of volume that you take in a normal breath. So not the amount of volume in your lungs when you're breathing, but the amount of volume of air that you breathe in a normal breath. That's your tidal volume. So you can see here, inhaling, exhaling, etc. The greatest amount of volume of air that you can breathe in is considered your total lung capacity. So in most people, that's around 5-6 liters. Some bigger guys, it can be about 7 liters. But that's your total lung capacity. So that makes sense. The total amount of air that you can fit into your lungs is your total lung capacity. Now that's different from your vital capacity. We have an amount of air that is always in our lungs, and that is important because it keeps the alveoli from collapsing. So if you were to breathe out all the amount of air that you can breathe out of your lungs, the amount that's still remaining is your residual volume. And this graph has it at about 1.25, but it varies based on your size. So that's your residual volume. You can't breathe that out. So when you have your total lung capacity, which is the total amount of air that you can possibly fit in your lungs, and the residual volume, which is the amount of air that's still there when you've totally expired as much as you can, the total lung capacity minus the residual volume is your vital capacity. So the vital capacity is the amount of air that you can bring into your lungs. So going from the most exhaled to your most inhaled. Okay? So the total lung capacity, the vital capacity, the residual volume, and the tidal volume, which remember is the amount of volume that you take in a normal breath, those are going to be 4 important values to remember. These other values, the inspiratory reserve volume, inspiratory capacity, expiratory reserve volume, functional residual capacity, those are good to remember, but these 4 that I highlight in yellow are important to know the definition of what they are. Okay, so there's another way that, so this is just telling a person to breathe in, breathe out as normal, then breathe in as much as you can, then breathe out as much as you can, and so forth. Well, there's another way that we can measure this, and what we're doing here is with the forced expiratory volume is we're telling somebody to breathe out as fast as they can. And this is going to be really important when it comes to determining if a patient has an obstructive disease. Because remember, if you have an obstruction, it's going to be difficult for you to breathe in and out because you have an obstruction getting in the way. So here we have somebody with their tidal breathing. And these numbers don't exactly correspond with the numbers on the other graph. That's not really important, though. because the numbers can vary from person to person. So here we've got somebody breathing in and out, the tidal volume. It looks like a tidal volume of about a little less than 1 liter here. And now they're breathing in as fast as they can, and they get up to about 7.25 liters. So that's this person's total lung capacity, because that's the total amount of air that they can bring into their lungs. Now we're telling them to breathe out as fast as they can. And as they breathe out, they're going to reach their residual volume eventually, because remember, the residual volume is the amount of air that remains in your lungs when you've totally breathed out. Now, what we can measure with when somebody breathes out as fast as they can is an FEV1. So when you're breathing out as fast as you can, we can have a machine that measures how much air you have blown out in a given amount of time. So the forced expiratory volume is the amount of the volume of air that you forced yourself to breathe out. The forced expiratory volume with a little 1 after it, the FEV1, is the amount of air that you can breathe out in 1 second. So you can see here now with our graph, we've got lung volume, which is really, you can also think of it as the amount that you breathed in or breathed out, and then and then over time. So we start out at 0 seconds, and this is when we tell the person to breathe in. We start out at 0 seconds when the person has breathed in as much as they can. Now we start the time, and they're going to breathe out as fast as they can. So once we get here to 1 second, that's the point where we're at our FEV1. So from our total lung capacity to our FEV1, that's going to be the amount that they can breathe out in 1 second. So here we're at 2.25 meters to like 7.3 meters. So the difference between that is your FEV1. And then they continue to breathe out until they reach their residual volume. Now, the FEV1, which is the amount that you can breathe out in 1 second, divided by your FVC, which is your functional vital capacity, or your forced vital capacity, which is the total amount that you can breathe out from your total lung capacity to where you hit your residual volume, when you can't breathe out anymore. When you divide those two, FEV1 over FVC, that number should be greater than 80%. If it is not, if it's less than 80%, then it's likely that the patient's respiratory problems are an obstructive problem. All right. And obstructive lung diseases, as you probably know, include COPD and asthma. So let's do a little problem here. So a patient's total lung capacity is 7.3 liters, and their residual volume is 1.2 liters. What is their forced vital capacity? So we know that our total lung capacity is 7.3 liters, and we know that our total lung capacity is our forced vital capacity, which is the amount that we can possibly breathe in, the volume that we can possibly breathe in from our totally exhaled to totally inhaled. So our total lung capacity is our forced vital capacity plus the residual volume that's always there even when we're totally exhaled. So we know our total lung capacity is 7.3 liters. Our residual volume is 1.2 liters. So our total, our forced vital capacity is 6.1 liters. Since we know the most air we can bring into, that we can have in our lungs is 7.3 liters, and the residual volume is 1.2 liters, we know that the difference in that is 6.1 liters that we're breathing in. Okay, now we know our forced vital capacity. Now we're having the patient breathe into this machine. The amount that they are breathing out in 1 second is about 5 liters. So now we want to know what the FEV1 over FVC ratio is. And since we know FVC is 6.1 liters, and we know that they can breathe out, in 1 second they can breathe out 5 liters, then or 5.1 liters, then we know that their FEV1 over FVC ratio is 81.9, so this is normal, and this would be in a normal person. So it doesn't really matter. Well, if we're looking for an obstructive disease, the volumes aren't so much important. It's the ratio. And we're going to look at restrictive diseases where the volumes are actually more important than the FEV1 FVC ratio. Okay, so another way that this is measured as far as looking at obstructive diseases is the forced expiratory flow from 25% to 75%. And this is just for your information. You don't really need to know how to equate this. This is just really strict physiology here. But all it's doing is it's measuring the amount that the person has exhaled over time, and you're plotting at 25% exhaled, at 50% exhaled relative to the forced vital capacity, 75% exhaled, and then 100%, and then you're drawing a tangential line from 25 to 75. Of course, there's some calculus in it, and this measurement, when compared to a normal patient, if it's lower than normal, that can indicate an obstructive disease. All you need to know is that if your forced expiratory flow from 25 to 75 is low, then that can indicate an obstructive disease. And the reason I bring this up is not to confuse you, but it's because the FEF 2575 is actually a more specific and more is an earlier predictor of obstructive disease than your FEV1 over FVC ratio. But the FEV1 over FVC ratio, you do need to know how to equate for the USMLE. This, you don't need to know how to equate, but I did show you how to equate it for your information. Okay, so what is obstructive versus restrictive lung disease? And you should know this because this is a review for USMLE step 2 and 3, but both involve difficulty breathing, dyspnea, shortness of breath, chest pain sometimes. Those are all going to be common symptoms that are common to the two of these. With obstructive disease, it's primarily difficulty with expiration. So it's really both difficulty with inspiration and expiration. But patients with obstructive lung disease have difficulty fully emptying their lungs. And they also have difficulty doing it at a fast enough rate. So they're going to have difficulty inspiring at a fast enough rate, and they're going to have difficulty fully emptying their lungs. So this is really mostly a disease of volume flow rate. So there's air trapping with obstructive disease. If you look at a chest x-ray of a patient with obstructive disease, particularly with COPD, you may see diaphragmatic flattening. And any obstructive disease involves a mechanical obstruction of the airways. So different obstructive diseases can include asthma, COPD, cystic fibrosis, and bronchiectasis. On physical exam with obstructive disease, you're going to hear wheezes, rales, and chest x-ray can show a flattened diaphragm. And what the wheezes are the collapsing of the alveoli. And that's what we see in COPD. Is that we see the collapsing of the alveoli, and that's causing the obstruction. Okay, with restrictive disease, this is primarily going to be a disease with inspiration, but mostly with restrictive disease, what it is it's a disease of volume. You cannot get your lungs fully filled because the disease is in the tissue. So in the case of restrictive disease, you've just got this really thick, non-compliant tissue that can't be filled with air. It's similar to constrictive cardiomyopathy and heart disease, where you can't fill the heart with blood. That's similar to restrictive disease, where you can't fill the lungs with air. So here we have a problem with the volume. So a patient with restrictive lung disease can't fully fill their lungs, often as a result of diseased, stiffer lung parenchyma, and it involves diseased tissue or a physical impediment to expanding the lungs. So different possibilities here are interstitial lung diseases. There's lots of them. Sarcoidosis, scoliosis, so that's a physical compression of the lung of the chest cavity. Obesity, or the so-called Pickwickian syndrome, where the patient is so obese that they've got a physical pressure not allowing them to expand their chest cavity. Respiratory muscle fatigue, for instance, if a patient is in diabetic ketoacidosis and the respiratory rate's 28, 30 per minute, they can eventually go into muscle fatigue, where their accessory muscles are no longer able to continue breathing, and that is technically a restrictive disease. And then lung resection can give you a false positive restrictive disease on labs, and that's just because you can't fit as much air as expected into one lung as you can in two lungs. On physical exam with restrictive diseases, you may hear crackles, which are indicative of problems with the lung parenchyma, decreased lung sounds, which would be indicative of edema, shallow breathing, which would show the decreased functional residual volume, and chest x-ray would show a diseased parenchyma. It'd be like a hazy chest x-ray. Okay, so looking at those volumes that we talked about, obstructive versus restrictive disease. So the main thing with obstructive disease is that you get a decrease in your FEV1, or FEF 2575. With your FEV1, though, that's primarily what you're looking at. And when you have a decrease in your FEV1 because you have obstruction, that's going to dramatically decrease your FEV1 to FVC ratio. So the numerator goes down, the denominator roughly stays the same, and so your FEV1 to FVC ratio goes down. These other ones you can, you can consider looking at, but this is FEV1 to FVC ratio is the most important for understanding obstructive diseases. The total lung capacity does go up with obstructive diseases, and that's just due to air trapping. And because the total lung capacity goes up, the residual volume is going up too. So it's not because these patients suddenly have more volume to breathe, it's because they actually are trapping air in their diaphragm, and so now, well, not in their diaphragm, but in their chest cavity. So now, when they're making a normal breath, that total lung capacity is actually looking like it's higher. So it's really because their residual volume is going up. With restrictive lung diseases, really the best way to remember it is just all the volumes are going down. So your FVC is going down, your FRC is going down, your residual volume is going down, your total lung capacity is going down, because your tissue is just less compatible with bringing air in because it's diseased. Now, with FEV1 FVC ratio, with restrictive disease, it should stay roughly the same because your FEV1 is going to go down a little bit, your FVC is definitely going down, but sometimes the FEV1 can stay normal and the FVC can actually go down because the tissue is diseased. So if your numerator is staying the same and your denominator is going down, then the FEV1 to FVC ratio can actually go up, like way up. So that's something to keep in mind. But for the most part, when you're looking at volumes with obstructive diseases versus restrictive diseases, with obstructive diseases, FEV1 to FVC goes down below 80%. With restrictive diseases, all the volumes are going down. All right, so this is just to show you on spirometry what that looks like. So here we have an obstructive disease, and you've got a little bit of increase in your volume, but you don't necessarily need to, especially early on. But the most important thing is that your FEV1 to FVC ratio is below 80%. Here's normal, and then here is restrictive disease, where you can see here that it looks like a normal spirometry, but the volumes are decreased. So total lung capacity is decreased. That's primarily what we're looking for. Okay, so another way other than spirometry that we can look at breathing is flow volume loops. So just to get acquainted with this loop, we're looking at both the positive and the negative on the y-axis. So on the on the y-axis, we're looking at flow. So this is liters per second. On the x-axis, we're looking at lung volume. So you consider this like 1 liter, 2 liters, 3 liters, 4 liters, 5 liters, 6 liters. So the lung is becoming more inflated to the right, more deflated to the left. And then this is inspiratory flow because you've got a positive flow in and then a negative flow out. So this is a rate on the y-axis, whereas you've got a volume on the x-axis. Okay, so let's look at normal. So here we start out with our residual volume in our lungs. We're totally exhaled, and now we're breathing in. And of course, the flow is going to increase, the rate increases, and then now we go down to our what is our total lung capacity. So now we're totally breathed in. Oops. So we're totally breathed in, and this looks like 1, 2, 3, 4, 5, 6, so like almost 7 liters of total lung capacity. So here's our total lung capacity. We're totally breathed in. Now we're going to breathe out. So this is expiratory flow down here. So we're expiring, and we're going back down to our residual volume. Okay, that's normal. With an obstructive disease, so we may have a little extra residual volume from air trapping. You don't have to, but that's a finding that you may see in obstructive disease. So here's your residual volume here. Now notice the slope is a lot different. The slope is lesser. It's a slower flow, and you don't reach as high of a peak flow. And so that's part of obstructive disease, because remember, obstructive disease is a disease of flow. So we don't get as high of a flow. We do reach a total lung capacity, and that total lung capacity may be higher due to the increased residual volume, and then the exhalation. So notice the increased volumes with the elevated residual volume and air trapping, and the lower maximum rate. Okay, so now with restrictive diseases, it's really the same as normal as far as the rate and everything, but the volumes are less. So you have less of a residual volume. You get the same rate, maybe a little less as normal, but you don't get as much of a total lung capacity because you can't bring as much air into your lungs because they're diseased. And so we don't reach as high of a total lung capacity. This is obviously an exaggerated graph, but you get the idea. And then the residual volume, again, is less. It may be the same. But the point is, with restrictive diseases, it's a problem with volumes. So you got a smaller volume. So with obstructive diseases, it's just a lower rate of flow. With restrictive diseases, it's lower volumes. Okay, so let's look at the AA gradient. So the AA gradient is one of the ways we can tell whether a disease, if a person is hypoxic, it's one of the ways we can tell, is this because of the lungs or is it not because of the lungs? So if a disease is because of the lungs, then there should be an elevated AA gradient. So what is an AA gradient? It's just determining the difference in partial pressure of oxygen in the alveoli between the arterial circulation. So the higher the AA gradient, the more problems the lung is having, because you're getting high oxygen in the alveoli because you're breathing in, but you're not getting that oxygen into the arterial circulation. So a discrepancy here is a problem because it shows that we're breathing oxygen in, we're getting the oxygen there, but it's not getting into the arterial circulation. And clearly, if that's not happening, that's a problem of the lungs. So this measures efficiency. And the higher the gradient is, the less efficient the lungs are working. Because you can breathe in a ton of air, a ton of oxygen into your alveoli, but if it's not crossing over into the arterial circulation, then you've got a problem in your alveoli to arterial gap there. You're not getting the oxygen from your alveoli into your arterial circulation. So a normal AA gradient is 5 to 15 millimeters of mercury, and what you can really just consider anything above 15 millimeters of mercury in your AA gradient to be a lung problem. Now, it's very easy to measure the partial pressure of oxygen in the arteries, but how do we do that in the alveoli? And really, we pretty much can't. There are really difficult, elaborate techniques that you can do it, but we need to know how to do it based on lab values. So here's how it's done. So you just take the partial pressure of CO2, so this is CO2, and it's 150 minus 1.25 times the partial pressure of CO2. So you take 1.25 times the partial pressure of CO2, and you take that value and you subtract that from 150. So take a look at what this means. So if our partial pressure of CO2 goes down, then our AA gradient is going to go up. Because if this value here is lower, then it means that this value here, the PaO2 alveoli, is going to be higher because we're subtracting less from this 150. And that's going to be really important when we look at certain diseases that are not due to the lung itself that cause an increase in the gradient, namely asthma. Okay, so let's see. Okay, so hypoxemia. Okay, so what can cause a high AA gradient? Pneumonia, pulmonary fibrosis, or interstitial lung disease, pulmonary edema, pulmonary embolism, pulmonary shunting, COPD, and asthma. So all of these are going to cause a discrepancy in the AA gradient. Now, the reason I brought up asthma, so you would think, why asthma? Why is that causing a difference in the alveoli arterial gradient? There's no problem with the lung tissue. And the reason is because what's going on here is the patient is breathing out, but they're not getting the oxygen in. So as they're breathing out the CO2, their partial pressure of CO2 is going down. Their partial pressure of CO2 is going down. Yes, their partial pressure of oxygen is going down in their bloodstream, but their partial pressure of CO2 in their bloodstream is also going down. And so since this unit here, 1.25 times partial pressure of CO2 in the artery, is going down, then the 150 minus 1.25 is going to be relatively higher, since you're going to subtract a lower amount from 150. And so it's actually going to cause the AA gradient to go up. So any of these things, pneumonia, pulmonary fibrosis, pulmonary edema, pulmonary embolism, pulmonary shunting, COPD, or asthma, they all cause an increase in the AA gradient. So with pneumonia, pulmonary fibrosis, pulmonary edema, that's obvious because you're getting a decrease in diffusion. It's actually the tissue that's the problem. With pulmonary embolism and pulmonary shunting, you're getting a decrease in perfusion because the blood is not going to the oxygenated areas. With COPD and asthma, like I mentioned, you're getting an increased minute ventilation, but you're not getting oxygenation to the blood. You're only excreting CO2. And so your partial pressure of CO2 goes down, but you're not getting any change. If anything, your oxygen level is going to go down because you can't get the oxygen delivery. You can just get the CO2 out. So your CO2 goes out, your partial pressure of CO2 goes down, meaning this value here, 150 minus 1.25, partial pressure of CO2 goes up, it's higher, and this leads to an elevated AA gradient. Okay, so the AA gradient is telling us, is it a lung problem or is it not a lung problem? And so what causes the normal AA gradients in hypoxemia? Well, it can be decreased respiratory effort, like on opiates, this should say opiates, OD, not obesity, OD. Okay, so if you're on opiates and you're only breathing 4 times per minute, then you're not breathing enough. But your AA gradient is going to be normal because you're getting the normal result due to your expiratory efforts. You're getting a very high PaCO2, and so that's going to result in a normal AA gradient. With obesity, you're not getting as much expansion. So these are all problems that are not due to the lung itself, not due to the lung unit. It's due to something that's not allowing you to expand your lungs, or something that is nervous in related, so like Guillain-Barré syndrome, or any other disease that reduces your breathing. And then altitude, so if there's less oxygen in the air. So anything that decreases your ventilation or decreases the amount of oxygen in your environment. So all of these are not lung related. They may be lung related in that you're not breathing as much, your respirations per minute are less, but they're not a disease of the lung. So these are normal AA gradients. These are high AA gradients because they're a disease of the lung. Either because they are decrease of the PaO2 or an increase of the PCO2. Okay, hopefully that's clear. Okay, now let's talk about the diffusion capacity of CO. So the carbon monoxide diffusion capacity is a way that we can decide if it is a lung disease. Is it a problem of the tissue of the lung? Is it a problem of the microscopic tissue of the lung, the alveolus to pulmonary capillary microunit, or is it a disease somewhere else? So remember what happens in the alveolus. The oxygen goes into the pulmonary circulation, and the carbon dioxide comes out and goes into the alveolus and then is expired. Actually, it's a little more complex. You get bicarb, which then goes to water and CO2. And that's sort of what is happening in the blood at this time. So what we use CO for is as a surrogate for oxygen, and we're just going to read this in the lab. We're not giving the person obviously toxic amounts of CO. We're giving them a mixture of CO and helium, but this is a way that we can measure how gases are crossing the alveolus capillary unit. So the CO goes in, it goes in through the bloodstream, it's read by the lab. So what we're asking here with the CO diffusion capacity is what might reduce the amount of CO or oxygen from getting into the blood. So things like fibrosis. If you have fibrotic lung tissue, then it's going to reduce the diffusion of gases through the lung tissue. If you have edema, that's going to reduce the diffusion of gases through the lung tissue. And if you have obliteration of the lung tissue, if you have obliteration of the alveolus, so remember in emphysema, the alveoli are consolidating. And so if you have less surface area for transfer, then you're going to have decreased diffusion capacity, because that diffusion capacity is dependent to a certain degree on that surface area. Remember, our lungs have the surface area of a tennis court. So if you have less surface area, then you're going to dramatically decrease your gas transfer. So a person can have obstructive or restrictive lung disease and have a normal or abnormal diffusion capacity. What the CO diffusion capacity, the DLCO, is measuring is whether this is a disease of the lung tissue or whether it's a disease of something else, be it non-pulmonary or like asthma, where the disease is more bronchial or higher up in the respiratory tract. Okay, so with obstructive diseases, if you have an obstructive disease with a normal DLCO, that's likely asthma. So with asthma, you get oxygen to your alveoli, But the problem with asthma is that you're not getting enough of it. But the asthma that you get to the alveoli is fine. It can transfer across. There's no problem with diffusion. It's just the problem is higher up in the respiratory tract. With obstructive diseases that have a low DLCO, so a disease of the tissue, that's emphysema. So remember, with emphysema, it's actually a disease of the alveolus, so you have a decreased surface area. And these are the most common obstructive diseases. So remember that an obstructive disease that has a normal DLCO, it's asthma. With a low DLCO, it's emphysema. With restrictive diseases, if you have a normal DLCO, it's likely extrinsic causes. So Guillain-Barré syndrome, myasthenia gravis, obesity, chest wall deformities like kyphosis, scoliosis, anything that's extrinsic, non-pulmonary. Everything else with the restrictive diseases, you should have a low DLCO, because remember what the restrictive diseases are. They're like fibrosis, sarcoidosis, anything that diseases the tissue. Most of the restrictive diseases are diseases of the tissue. So most restrictive diseases will have a low DLCO, but the ones that don't, they're extrinsic causes. So either neuromuscular, obesity. I suppose you could have a restrictive, something that shows up like a restrictive disease where you have reduced volumes, but a normal DLCO, let's say if you only have one lung. So like the Pope, for instance, he's only got one lung. He'd have less capacity, less lung capacity because he only got one lung, less residual volume. All those measurements would be smaller if you only have one half of your lung, but the diffusion capacity across the alveoli into the capillaries is normal because the tissue is fine. And so with a normal DLCO with a restrictive pattern, it's likely either extrinsic or it's false positive because you only have one lung. So those are some things to think about that. Okay, so just a review, obstructive versus restrictive, they both involve difficulty breathing. Obstructive diseases is primarily, I would disregard what I say, they're both really difficulty with inspiration and expiration. Patients with obstructive lung disease have difficulty fully emptying their lungs, and they have difficulty breathing in at a normal rate. It takes them longer to get their lungs filled. They also have difficulty breathing out at a fast enough rate sometimes. There's air trapping, and generally this is going to involve a mechanical obstruction of the airways, although it can be a microscopic obstruction of the airways. So asthma, COPD, cystic fibrosis, bronchiectasis. We'll talk about these in greater detail as we go into more details of the pulmonary diseases. Restrictive diseases are primarily parenchymal in nature. It's a disease of the tissue, stiffer lung parenchyma, or there's some kind of physical impediment or neuromuscular impediment. So interstitial lung diseases, fibrosis, sarcoidosis, scoliosis, obesity, respiratory muscle fatigue, or lung resection like I just mentioned. The things you can see in that, crackles, decreased lung sounds, etc. And these are some things that, we didn't talk about all of these, but these are some things that you can use in differentiating obstructive versus restrictive. We talked about spirometry, saturation, getting a chest x-ray, carbon monoxide diffusion capacity, of course, the AA gradient. With obstructive disease, particularly in differentiating between asthma and COPD, a lot of times it's clinically obvious. Most 5-year-olds don't have COPD, and most 65-year-old smokers don't get a new diagnosis of asthma. But you can use a methacholine challenge and a bronchodilator response to see if it's due to more of an upper airway problem versus a lower airway problem. We'll talk about this in greater detail when we talk about asthma and COPD. With restrictive diseases, to determine the exact restrictive disease, if it's a parenchymal disease, biopsies are going to be helpful for that, and bronchoalveolar lavage. Just a review of the different tests. Hypoxemia is low oxygen, so that can be due to a respiratory or a cardiac cause. So if it's a respiratory cause, either you're not ventilating or you're not perfusing correctly. If it's cardiac, you're not pumping. Both of those can cause hypoxemia. Hypercapnia is high CO2. This can be due to and that's partial pressure of CO2. That can be due to a respiratory cause, either not expelling via ventilation and perfusion. It can be due to a cardiac cause. So if you're not getting your CO2 to your lungs, then you're not going to be able to breathe it out. Or it can be due to a metabolic cause, meaning that you're actually getting an elevated bicarb, so you're going to have a higher partial pressure of CO2, but it's metabolic in nature due to the fact that you're creating more carbon byproducts. So remember how you differentiate between respiratory and metabolic acidosis. Okay, the AA gradient measures the efficiency of gas exchange between the alveolus and the artery. And so an elevated AA gradient indicates the hypoxia is due to a respiratory or a lung problem. The DLCO test tests the ability of CO, which is an oxygen surrogate, to diffuse across the alveolus and the parenchyma. And that is focusing on whether it's a tissue disorder. So a low DLCO indicates a low diffusion capacity, indicates a disease of the alveolar parenchymal unit. So alveolar if it's COPD, parenchymal if it's usually a restrictive or a lung tissue disease. And this is my dog Axel. He just celebrated his 2nd birthday. So they make dog cupcakes at the bakery not too far from us, so we got him one of those. So, anyway, there'll be some more respiratory lectures in the coming days.